Hello friends, welcome to Srinitralay. In this case, I am going to perform Phaco emulsification and pteyrgium excision with GRAFT with my own technique. This case was a small pupil also, so I used phenocane for pupil dilatation. Once the pupil is fairly dilated, anterior capsule is stained with trypan blue. In all small pupil cases, it is good idea to stain the capsule so as to have a good visibility. Rhexis is performed with 26 gauge cystitome needle. In my practice, I usually perform a pterygium surgery and then wait for 4 to 6 weeks. Once the healing is complete, then I usually take up the cataract surgery. But cases where you cannot take the patients multiple times in OR, in such scenarios, in small pterygiums which are not affecting the corneal astigmatism, these kind of pterygiums with cataract I usually operate together. And a hydrodissection and hydrodelineation is performed with 27 gauge cannula. Nucleus is well rotated in a bag. Once phaco emulsification started, loose fluffy cortical material is taken out, and that way it creates more room for manipulations. So once this is done, a first crack is made. I am using a side cut chopper. Once the nucleus is divided into 4 quadrants, each quadrant is taken out of the bag and is phaco emulsified in Phaco 2 mode at pupillary plane. That my left hand is assisting the right hand and the phaco emulsification probe in my right hand is in center all the time during phaco emulsification. Once phaco is completed, a cortical plate behind is taken out with suction. During IA, I usually start subincisional. Here I am using a coaxial irrigation aspiration cannula, and the movement of sweeping side to side is done so that I can have more amount of cortex which will block my IA tip, and I can take the cortex within fraction of seconds out. IOL is implanted and I am using my left hand to dial the IOL directly into the bag so that I can have IOL in the bag within very short span of time without giving it chance to go into the sulcus or to open up in the AC. Visco wash is done on high IA settings and visco behind the IOL is taken out with the help of IA probe. Now, before proceeding for pterygium surgery, I am injecting a large air bubble into the anterior chamber so that I can have a nicely formed globe for excision of pterygium. This air bubble in anterior chamber also prevents fluid from cul-de-sac to enter the anterior chamber during the rest of the procedure. Mark the area of conjunctival tissue to be excised. It will help you 1. To prevent loss of normal conjunctival tissue. 2. You will have a good cosmesis post-operatively as you know exactly what size and shape of graft you need. Now note, because of marking, how nicely demarcated host area we are having to be grafted. Once the pteyrgium is excised of the corneal tissue, the corneal surface is smoothened with the help of diamond burr. It is very important to have smooth corneal surface post-operatively, as it will make sure even distribution of tears and patient will not have any foreign body sensation. It will also help in removal of superficial corneal scars. Now the caliper is used to measure the amount of graft needed for proper sizing. Keeping the caliper prongs in the same position, they are marked with junction violet. Now these markings are made on the graft area so that we will have exact amount of conjunctival graft as that of host area. Conjunctiva is ballooned with subconjunctival fluid injection, and the same 26 gauge needle is used as a cutting tool perpendicular to the limbus, and these cuts are very superficial so that we will have only the conjunctiva to be involved in the cut and not the tenons area. Now using blunt tip scissors, conjunctiva is separated from underlying tenons very superficially. You can use your left hand to tighten up the conjunctiva so that you can have a good dissection as shown in the video. The posterior lip of this graft is freed. Once this posterior lip of graft is freed, I always used to find it difficult to hold with normal forceps. So in collaboration with Epsilon, we have designed a forceps which is stout, atraumatic. It has a V-shaped groove. This particular forceps can be utilized for conjunctival tissue handling for any surgery like glaucoma surgeries, squint surgery, or any other situation where you are supposed to handle conjunctiva. Because of this forceps, I am no more leaving my posterior lip of graft, and I am getting quite regular and uniform results for removal of this graft. This graft is very thin. As you can note, it is devoid of any tenons tissue, and it is very transparent as it is very thin. We don't want tenons with this graft, as tenons is an elastic tissue and it contracts post-operatively, leading to contracture of a graft and thereby causing edema under the graft and chances for dislocation of this graft. To have a glueless, sutureless pterygium surgery, it is important to have this thin tenons free graft. Once the graft is ready, the orientation of graft is maintained to the limbal side correctly and it is slid onto the host area. Once the graft is in position, undermine the all edges of graft so that it will not dislodge post-operatively. Also remove underlying fluid which also can dislodge the graft. Now note, the graft is very thin. You can see underlying vessels below it. Do not leave any fluid near the graft so that it can sip under the interface and can lift the graft. Hope you have enjoyed this video. There were many tips for both Phaco and pteyrgium in this particular video. Do subscribe to YouTube channel Dr. Pankaj Lande for more such exciting videos. Thank you and good day.